Good morning. Today's topic of discussion is on bladder tumors. Essentially, bladder tumors commonly refers only to the transitional cell carcinomas, or in today's terminology, urothelial cell carcinomas. Now, this subject typically nowadays belongs to the field of urologists. Where do the general surgeons come in? General surgeons come in the diagnosis, in suspecting that there is a bladder tumor. And second thing is, a part of the treatment might fall in the domain of general surgeons. So it is important for us to know what are the etiological causes, what is the type of presentation that it gives, and some parts of the diagnostic components. So the lecture will be delivered keeping in mind that there are certain sections of this lecture which today belong largely to the urologists. Now here, of course, is a picture of a bladder tumor. It's actually a picture of squamous cell carcinoma of the bladder, which has involved the anterior wall of the vagina. What are the different types of bladder tumor? It's a common urological cancer, right? Highest recurrence rate of any malignancy. For example, if you treat a case today, it's quite likely that it recurs several times during the first year after the treatment. So this is one of the phenomena that you have to keep in mind when you are treating bladder tumor. And the most common variety, like I said, is urothelial carcinoma. The next one is squamous cell carcinoma, and a third one is an adenocarcinoma. For example, the one that is arising from urethus is typical case of adenocarcinoma, and also sometimes rhabdomyosarcomas, carcinosarcomas, lymphomas, etc. Squamous cell carcinoma, the one that typically arises out of chronic irritation, for example, a stone in the bladder. So we will talk essentially more about this because this is the commonest carcinoma. Others as they come along. Now, are there any risk factors? If a patient presents to you with haematuria, and you start taking his history, it's a good idea to know what are the different risk factors. Are they there or not? And the most important and commonest risk factor is smoking. Because smokers, for whatever reasons, it is not specifically known whether it is at a genetic level or is it at the level of the cellular level, but smoking somehow makes a man prone to carcinoma bladder. All the chemicals which get into the circulation after smoking finally will enter the kidney and are cleared out in the urine. And once they are cleared out in the urine, that gets stored in the bladder prior to maturation, and there's enough time for these chemicals to act upon the urothelium of the bladder. So this is one very important risk factor, and that should be kept in mind also when a patient is undergoing treatment, because quite often many patients give up smoking just when they are told prior to therapy and restart again during the follow-up. So this should be therefore kept in mind. What about family history? Yes, there are indeed some genetic factors which make family members prone to this particular tumor. But there is also this factor that a certain group of a family might be working in the same kind of industries, for example. For instance, a father working in a rubber factory or a print factory might have a son who is similarly working. So therefore, there is this exposure to chemicals which is common between the members of a family, apart from the genetic. And also cases like Lynch syndrome, where carcinoma colon is very common. For whatever reasons, bladder tumors are also common in that particular group of people. Chemical exposure, particularly aniline dyes, the first of the chemicals that were found to be incriminating is aniline dyes. That is, and also those people who work in dye manufacturing industries, in printing presses, and such other industries. So constant exposure to chemicals, discharged in urine, exposure to the urothelium, they are carcinogenic in nature. Chronic irritation, those of us who work in the field of surgery should be very cautious. Long-term catheterizations, it is not uncommon, particularly in a urological OPD. you will find a large number of patients who come with catheters in place for months together, sometimes years together. So if you have a long-term catheterization, or somebody who's got a stone in the bladder, constant irritation, and the catheters also form phosphatic encrustations around the catheters, and these also cause irritation. So any kind of chronic irritation can give rise to a malignancy. You have seen one picture of squamous cell carcinoma, which I have shown you right in the beginning. So chronic irritation, or even cystitis, for instance, chronic cystitis can make you prone to a malignancy. So it's very essential to remember long-term exposure to irritation. Age, somehow men beyond the age of 70 are more prone to CA bladders. So, gender also, I mentioned, it occurs more often in men than in women. There are situations where prior radiation has been given. It may be for any type of cancer. Prior radiation has been given to either to the lower abdomen or to the pelvis, and that makes the bladder therefore prone to formation of cancers. So prior radiation is important, and anti-diabetic drugs, particularly pioglitazone, has been known as a risk factor for carcinoma of the bladder. So these are the various risk factors, and when a patient comes to you with hematuria, it's a good idea to find out what went into producing that, and particularly if carcinoma bladder shows up in further investigations, because there may be some correctable factors in these. For example, pioglitazone withdrawal, or for example, control of smoking. So let's have briefly look at the pathophysiology. As it is written here, urothelial carcinoma arises from stem cells. And where are these located? They are just adjacent to the basement membrane of the epithelial surface. If you typically draw the wall of the bladder, then you see you'll have about 3 to 5 layers of epithelium. And just below that will be the basement membrane, then lamina propria, then muscles, right? Superficial muscle and deep muscle. So these we'll talk about later. This is very important. Then we have the perivesical tissues with fat around. So this will be a typical cross section of a bladder wall. So if these stem cells are located somewhere here, they are adjacent to the basement membrane of the epithelial surface. And depending on the genetic alterations that occur, these cells follow different pathways in the expression of their phenotype. So that means if there is a genetic predisposition, therefore, there can be changes in these cells. Now, this is a very important, this statement is very important. Bladder cancer is described as a polyclonal field change. In other words, all those areas which are lined by urothelium, for example, starting from the calyces and the kidney down up to the bladder, all along lined by urothelium. And all this is potentially prone to the same malignancy. In other words, it's a field change. That is the word. That's the reason why it is written polyclonal field change, right? So there is a field change defect. And so if there is a heightened potential in the bladder, there will also be a heightened potential in the urothelium of the kidney and ureter. So for example, if you have a typical TCC, transitional cell cancer, involving the pelvis of the kidney, then you're supposed to take out the kidney also, the ureter also, with a cuff of the bladder epithelium. And this is the reason why we do that, because this is considered to be a field change. Of course, genetic defects of various types are also documented, and they impact the treatment. So if I have to remember only one sentence out of this particular slide, I will remember this, that it is a polyclonal field change urothelium. So any part which is lined by urothelium becomes prone to malignancy if one area shows malignancy. Right, so now let us look at how does bladder cancer present. This is the outstanding, scintillating symptom of bladder cancer. painless, gross hematuria. We are not talking about microscopic hematuria. We talked about microscopic hematuria in another lecture. And for example, tuberculosis is the cause of microscopic hematuria. This is a gross hematuria, and anybody can see it. And approximately 80 to 90% of patients present with this symptom. But there are times when you have other symptoms which mimic bladder cell, which mimic various other conditions. Let's look at the next one. Irritative bladder symptoms. Dysuria, urgency, frequency of urination. What is this? This is Lutz, isn't it? This is the symptom which we normally expect with hypertrophic prostate, or even for that matter, any kind of outlet obstruction. This is Lutz. So in 20 to 30% of patients, the presentation is like this. They present with this kind of symptoms. It may be because there is already a tumor sitting at the bladder outlet and giving rise to these symptoms. It may be so. It may also not be so. For example, carcinoma in situ can give rise to this particular symptom complex. So irritative bladder symptoms. And of course, if by chance there has already been a metastasis, then pelvic or bony pain and a lower extremity edema, we will see when we talk about the lymphatic drainage of the bladder. Involvement of the lymph nodes in the pelvis would obviously affect the lymphatic drainage of the lower limb and give rise to a lower extremity edema. There can also be a flank pain if there is advanced disease. But it is very rare for you to have a palpable mass on physical examination. It is rare, and definitely not so in superficial bladder cancer. What is this? We'll talk about it later. Not so much not at all in superficial bladder cancer. Usually this mass is because of either the presence of a large clot in the bladder or some kind of a retention which is going on, and that gives rise to a palpable mass on physical examination. So this is rare. So thing to remember, this gross hematuria, and next is to remember the irritative symptoms. These things are important clinical presentations.